Uh, Boyd Haley was the actual information giant. I'm here for just humor, I guess. The stuff that I've done, I'm a pathologist, I'm a dentist, and I think, the only dentist walking the planet who has ever taken a bone pathology fellowship. I have no idea where my interest in bone comes from, but in my career, most of the research that was available has sort of, it's, we'll say it's not animal research, it's not heavy duty stuff, but it's been very, very interesting, and a lot of it has been new. It's a good thing I had that bone pathology fellowship because, and that was at the Mayo Clinic, by the way, under Dave Darlene, who was the chair of pathology, and he had the #1 textbook in bone path at the time. But he stimulated my interest, and I just kept it going. And then one day I happened to get a patient in a lot of pain, had been diagnosed as a trigeminal neuralgia patient. And I'd heard of this kooky oral surgeon in my state, West Virginia, and that he was treating these, going into the jaw and scraping things out. And I drove down to his town and talked to him about it, and he seemed just fine. And he'd had hundreds of these lesions that he had treated. So that's how I got started. That patient, after he treated her, had zero pain, and I followed her for another 15 years. But I had that bone pathology fellowship, and I was really curious, what's going on with this? And quite frankly, in my career, I've probably read more orthopedic literature than I have oral pathology literature. Well, there's a lot more of it to start with. So I also wanted to mention before I get started, actually, that like Boyd, I think my first talk to this group was back in 1993. And I want to tell you, it's some of my really good friends in this world are in this organization as well. But I have a little bit of a problem with this organization because I was young and thin, and look at what's happened to me because of this organization. So, well, I do also want to emphasize that, in fact, I was young once. And I have arthritis in my knees, and so and I'm very active in the American Academy of Oral Medicine. I've been on their board of trustees for maybe 7 or 8 years, and I complained about my arthritis, so they gave me a special award at one of their meetings. I called me up on stage and gave me a bottle of Geritol because they thought I was complaining about being old. So those of you who are young, I just want to let you know, this is the way it's going to go. I have been, when I started Oral Path, nobody shared their material. I was trained by a guy in Minnesota, Bob Gorlin, who was probably the only, well, there was another one. There were 2 people in the whole country in oral pathology who actually would share their teaching material. And Bob was kind enough to do that to me. And so I have tried to pass it forward, and I have developed, it used to be on a CD. Now it's just a bunch of PowerPoint presentations in a Dropbox. It's called the Bouquot to Go. It's not my name. Somebody called me one day and said, "Can you send me that Bouquot to Go disc?" And it's just got a bunch of PowerPoint presentations, about 3,600 pictures, mostly clinical, and I own the copyright, so you are welcome to use those any way you want. A bunch of people have taken my pictures and put them on their office websites to make them look a little more scientific, whatever. But if you want, this has the link to Bouquot to Go. You can just call me or email me would probably be the best. And this whole presentation, this organization has a copy of it, so you're welcome to take that. And then I said that Bob Gorlin was one of my mentors, but I also spent a year in Denmark on another fellowship. And Jens Pinborg was my mentor over there. So since they have died, I have been dedicating pretty much all of my CE to them. So I was intrigued by what goes on in the jaws, and this guy, Dave Darlene, my mentor at the Mayo Clinic, once made a comment. He said, the jaws are really different, aren't they? Because I had told him about one odontogenic cysts and 2 odontogenic tumors that he'd never heard of. And I convinced him that those are real. And this is the biggest name in bone pathology. He got tissue from all over the world, literally every day. So that was kind of an eye-opener to me as well. Oral path has a special place in the path world. We get along very well with the medical path people. And I just finished, told some of you, I just finished a 270-page manuscript, a book chapter in the most popular head and neck pathology book, and that is, that's the 3rd edition of that book. Well, I decided to call this Who Knew, because I have even been surprised. I've been interested in bone, and I especially was interested in jawbones, but as the years went on and I learned a little bit more, I would pick up this one bit that made the jaws different from every other bone that I knew about. And I told you, I read a lot of stuff in the orthopedic literature. And I think I have a decent handle on what goes on in bone and the rest of the body. So I'm probably the only person who can make comparisons. And as the years went on, I just kept adding and adding and adding as I discovered something new or had thought about something new. Some of these are pretty obvious. And I'm up to now 22, and there might be a 23rd once I do a little more research. Well, I am going to not go through all of these because that's really not the topic, but let me get to the topic. Sorry, the buttons don't work very well with the presentation, but it should work fine on your computer. Okay, well, one of the greatest shocks that I ever had in my life was a paper in the top orthopedic journal called Bone, and they almost never put any oral path or dental kinds of articles in there. And this was 19 years ago now, 2010. 2 periodontists and 2 oral pathologists from the University of Maryland decided they've got all of these implant sites in edentulous jawbone, and why don't they just take that bone and trephine, take a core sample out of it, cut it lengthwise after being processed, and then look at it, see if they can find anything. And I'll show you the results of that. And I said it was a real eye-opener to me. And I can tell you at this point, even right now, over half of the edentulous bone sites in American jaws, I conclude from this paper, are diseased. They have either ischemic bone disease or chronic osteomyelitis. And you might not know this, but chronic osteomyelitis is a brand new entity. There have been a few papers in the jaws about it. And now, only within the last 5 to 7 years have we actually taken it seriously, that you can have an ongoing, forever kind of low-grade inflammation in your jaws. Well, let's look at the ischemic stuff first. We think of osteonecrosis today in dentistry as the bisphosphonate osteonecrosis. Before that, we thought of it as radionecrosis because until recently, most of the radiation that was done to the body was in the head neck area for oral cancer. And that was mostly because other organs got in the way in other parts of the body, and cancers of other parts, and the radiation was producing too much damage, whereas in the facial area, we could somehow live with that damage. Well, osteoradionecrosis is a minor part of the whole problem now, less than 1%, but back in my early days, 25%. You had a 1 in 4 chance of getting exposed bone in your jaws if you were irradiated for a tongue cancer. And so it was a pretty serious problem, and you know that it can be very, very painful. Well, if we look at osteonecrosis as a generic entity, however, there are a lot of things that we can find. Probably the oldest one is cocaine. If you read, I read a lot. I love to read the old British novels, and a lot of those people go to parties and they're snorting cocaine, and then in a few of them they'll be talking about having problems with their nose, their nasal septum. We've known for hundreds of years now that the nasal septum dries out and gets destroyed by cocaine particles. It's 95% vasoconstriction. That's a pretty powerful vasoconstriction. And the cartilage has no blood vessels, so it's sort of the natural target for something like that. And if you keep it up, eventually the powder will fall to the bottom of this defect and you'll have enough to even affect bone. And then one day you'll blow your nose and a whole bunch of really nasty stuff will come out of your mouth. And that's something, if you had a perforated palate back in the 1800s, your physician would have said you either had the third stage of syphilis, you had an end-stage tuberculosis, or you had cocaine use. And so it's not anything new. This is syphilis, same kind of a thing. There's a torus in front. And we have something that we have most of my life called midline lethal granuloma. Only fairly recently have we discovered that it's actually a lymphoma. It's a very unique one that puts all the bad cells, which don't look too bad, right around the blood vessels, so it looks kind of like inflammation. We used to call it midline lethal granuloma, and almost all of the cases actually were in the mid-face. And it is still considered a midline phenomenon and a facial problem, but if you want to see how bad it can get, it is mostly an osteonecrosis produced by the lymphoma. This is a case report I published. A Vietnamese fellow I met in Houston had the same problem, and you can see by the time I met him, he had most of his face gone from this disease. And most of it is osteonecrosis. Bone destruction, often without any pain at all. And Wegener's granulomatosis, or TOSM, some people write it out as. It is a disease that we couldn't understand until fairly recently. Now we know that it is sort of an immune system attack against our blood vessels, and they seem to congregate, especially the attacks, especially in the lungs and the oral area. So this picture is one of our state's Supreme Court justices from long ago, and nobody could figure out what it was. He had full perforation, and that white stuff is bone. It's not pus at all. This is the osteoradionecrosis, same as the bisphosphonate. You have exposed bone. And this is a bisphosphonate, just a piece that was exposed and eventually got so loose that the oral surgeon just pulled it out with almost the tweezers. And this is the first case of osteonecrosis I ever saw. I didn't recognize it. It was in a 17-year-old girl, and the damage was done because one of our dental students put the rubber dam clamp up a little bit high. You can see the shape is kind of fitting that. I followed her for about 8 years. She became a mother, a lot more responsible, and she finally admitted that she used a lot of cocaine when she was young, and she used every drug that she could find, and she thinks this was drug-related, whereas I thought it was probably something wrong with the immune system. I believe now this was probably a blood flow problem created by some drugs. We don't know yet, or we'll never know. And then there's another disease that doesn't affect the rest of the body and the rest of the bones. If you have, we talked earlier this morning, I think it was this morning, about do we have good bugs and bad bugs? And they're not all bad as we used to think. And so we have a bunch of bugs around our teeth that are pretty useful to us and keep many of the bad bugs in check. But if you're malnourished, especially protein deficient, and you get a disease, this young boy had pneumonia and essentially used up his immune system fighting that. And just when these kids are getting better, this stuff on their gums jumps out onto the rest of the buccal mucosa, usually from a little bite, a little trauma. And then it's sort of like a not very painful nug. A nug, same kind of a process, except it destroys the whole mouth. And that's called noma, cancrum oris. It has several different names, but you have to be protein deficient to develop this. And this, even if you're protein deficient, you don't get this kind of a problem in other bones in the body. And then there's the one that I first came up with. There was a lot of controversy around this dentist treating these facial neuralgias by going into bone that was supposed to be perfectly normal. And I thought, well, this is a good place to look at these things. And so I got this kooky oral surgeon, who was a wonderful man. He and I watched a lot of his surgeons, a lot of his surgeries in order to get an idea of what was going on. And eventually I looked at about 340 of his microscopic slides from his cases, and their own pathologists from multiple hospitals over the years had called them all chronic osteomyelitis. So I just told you, until recently, we didn't think that was much of a problem. It was a super rare thing in the jaws. And he had over 300 cases of the same kind of a thing. All of his patients, they came from all over the world to the mountains of West Virginia. And he would pray with his patients, and that was laughed at by the other oral surgeons. But he mostly could see something on the radiographs, and he did some testing that the rest of us just didn't do. And I couldn't see it on the radiographs myself. I took over 100 of the radiographs, and I put them in a box. I could only find a lesion 10% of the time. And then 4 or 5 years later, when I knew a lot more, had a lot more experience, I took those same radiographs out, and over 90% of the time, I could see where the lesion was. So it's not God showing him where the lesion is, it's just experience. And it takes subtle experience, and you have to want to learn, I guess. So this was called, this was called Ratner cyst when I first got into it. And there was a lot of controversy. Ratner was a pretty feisty guy out of New York City, and so he didn't mind the controversy. But you know, I grew up in Minnesota, so I don't like conflict at all. And so we had, I thought, well, the problem is we need a new name. And so I said, every one of my patients has facial neuralgia. They've been previously diagnosed with that. Every one of them, one of the most unique things about ischemic bone disease is cavitation. And many people in this room use the word cavitation for the whole spectrum of ischemic diseases, whereas the orthopedic surgeons have never, ever used it for anything except the hollow hole, the hollow space in the bone. That's the formal use of cavitation. So I said, well, let's put that in the name. And so I said neuralgia-inducing cavitational, and initially I called it osteomyelitis, but my first paper on this I gave in Ireland, and just literally 2 weeks before I submitted the abstract, I read my first paper on osteonecrosis of the hip. And I looked at the pictures, and there were all these things that I had been calling osteomyelitis for years. And so we ended up calling it osteonecrosis. Very fortunate as well, but also unfortunate. In the jaws, there's a lot of overlap. And I have many friends who would prefer calling this osteomyelitis rather than osteonecrosis. So Nico is a name, and in oral pathology, we have this very famous thing that happened during the 90s. They call it the Nico War, the Nico Wars. People were pretty nasty to me, and I never responded, and a whole bunch of my friends from all over the world got on. This is oral pathologists and oral medicine docs. We talk to each other. We've been doing that since the early 90s. We talk to each other, and so because of the Nico Wars, we had a rule. If you're nasty to anybody, you're off the list from that point on. Sort of like Facebook is getting to be now. So I went through the Nico Wars, and I kind of stuck to my guns, and it's just very, very interesting to me. I'm trying to figure this out. And one of the things that this interest led me to were there were 5 or 6 papers, some of them in patients who were alive but had chronic osteomyelitis. These are all European papers. But most of them were cadaver cases. One Finlander case of over 200 cadavers. They looked in the mandible to see what the inferior alveolar artery looked like, and the majority, almost all, like 80% of the arteries, these are old people who died naturally. That's where they got the cadavers. And almost all, 4 out of 5 of these inferior alveolar arteries were, these are the words from that paper, I think. You see, with age, the artery becomes usually minimized, constricted, atherosclerotic. I haven't seen much of that part. Tortuous, fibrotic, and even missing. And we have this concept of neuroplasticity that explains something that's been a real problem for me. I have looked in jaws. I've seen maybe 120 of these looking over a surgeon's shoulders. And I have looked in maybe 15 or so, 20 with hollow spaces, true cavitations. And 2 of those had a completely hollow mandible. And yet I would pinch their lip. We would give them a mandibular block. They would go numb all the way to their lip. It worked. If clinically, you would think this is a perfectly normal neural system in this person's mandible. And now with neuroplasticity, we know that if you crush a nerve, a big sensory nerve, that other nerve types can take over the process, and eventually you'll get the same neural sensations that the original nerve had. And this ischemic disease is a process that takes a long time, so the nerves, I'm sure, in those mandibles were capable of converting over a period of time. So I think the biggest problem, one of the reasons that I said, who knew? It's been out there since the 1970s, early 1970s, at least in Europe. They knew that inferior alveolar artery was a lousy artery. You don't get tortuous arteries in your other bones in the bodies. If you look in long bones in an older person, the artery is it goes right up to the end, turns around, and comes back down. And I have, in order to understand this disease at a microscopic level, I have literally gone to the experts from North America, Japan, Europe, and well, Japan would be the Asian ones. And I sent slides. Altogether, I've worked with about 15 of the world authorities in osteonecrosis of the hip. And they're all very generous. I spent a whole week in New York City in the hospital for special surgery, which is pretty much exclusively bone. And had a couple hundred slides. The chairman of the department was the expert. He had the most popular bone book. That's why I asked him if I could come up. And he gave me about 20 hours of his time. He was so fascinated that the jaw would have all this stuff the same as the hip. And everyone I looked to, no matter what country they came from, they said, well, what you're dealing with is the same as what we're dealing with. So it started out with me being really scratching my head, wondering what was going on. But once I decided this was a blood flow problem rather than a inflammatory or infection problem, then I got onto something went down a line that was much, much better. And I've done a few other things to try to figure out why this is happening. But I think one of the reasons it's happening, whether it's chronic inflammation or lousy blood flow, is the fact that it is in the jaws, and we have this problem with the inferior alveolar artery. I was so frustrated because the orthopedic surgeons and the pathologists, they got this big ball, the femoral head, and they could cut and slice it any way they want, and it really helped them to figure out the pattern of this disease. I had nothing. I had little chunks. Some of you have sent me tiny little chunks that other pathologists would say, I'm not going to even look at this. It's too small. But I know that there are hollow bones, and you have to scrape, just like a traumatic bone cyst, you have to scrape the walls in order to get a biopsy. So I had a friend who was in charge of the anatomy department in one of our med schools in the state, and he said, well, I'll look for some really well-preserved mandibles, and when the med students are done with them, I'll take the mandibles out. He only took half the mandibles. It became too much of a job to get the whole mandibles, and out of all of them, several hundred that he sent to me, only about 66 were microscopically and grossly in perfect, pristine condition. This is, I am about to send this off to the journal Bone, see what they say. But out of those 66, you see on the slide that we have 47% had some kind of focal problem. These are just people who died. But what I didn't understand was when we died, cadavers for med students years ago were the John Does and the Jane Does. Now the cadavers are donated by the people who have been in the hospital for a long time. Their bodies are no longer sacred vessels. because they've been picked and poked, and their body is just a body to them. So they volunteer to give their body to medical science and teaching. And so I figured these would be people, they've had heart attacks, cancer, chemotherapy, strokes, they have all the kinds of things that should make them systemically ischemic. And I thought, well, this would be a right place to a group of people to try to look in their jaws. And eventually, after 20 years, I had enough jaws, and the paper is now going to come out. But 47% had 46 different lesions in those mandibles, and these are only half the mandibles. I didn't look at the other side. Most of them were in the posterior molar and premolar area, and 50% of them were either touching or below the inferior alveolar artery. And some of you who have dealt with these kinds of lesions, if you know that, that would explain your failure cases. You would only know you failed, of course, if you have pain, so that pain would go away. However, if it didn't go away, seldom are you going to go beneath the inferior alveolar nerve. And if you don't do that, we have a 50% chance that you left something behind. Fortunately, this is a disease that curettages the treatment regardless of the bone involved, and you don't have to take it all out. What you're trying to do is get some really good fresh blood in there, and hope that you cross your fingers, of course, and hope that the bone fills in by itself. And look at the next figure. 96% of these were in edentulous sites in the jaw. Who knew? There's something that happens. I taught for 15, 16 years at WVU. Every orthopedic surgeon, surgery resident, spent a month in my office. I'd give them a little seminar in the morning, and then we'd have a little research project we'd work on. And I always waited until the very end, and then I would sit down and we're just chit-chatting, and we had all become friends by that point, 2 a year. And I would ask them, do you know what a dentist does when he or she pulls a tooth? And they give me things, well, they probably bring the tissue over and suture it all up super tight, the way the Germans used to do, actually. And I said, no, they just pull the tooth and throw it away. And they literally, everyone, over all that time, 2 a year, everyone was absolutely horrified. And, you know, we get away with it. How do we get away with that? That would never happen. If you're an orthopedic surgeon and you see exposed bone, like you would find in a tooth socket, the very first thing you want to do is cover it up so that you don't get any skin bacteria, external bacteria, because osteomyelitis in long bones is really hard to treat, especially as it goes into a chronic phase. Antibiotics don't help much. And unfortunately, you can end up with losing a leg or losing an arm or losing a hand. Anybody ever heard of losing a jaw because of even a periapical abscess? There are reports, but the jaws are different. The jaws have lots of different things. I think saliva is a really big help in our world. It keeps those sockets from getting super bad. So we're tossing in some good bacteria maybe with the bad bacteria. I don't really know why, but to remove a tooth and just throw it away without putting a really tight, trying to sterilize it as much as you do, and putting a really tight suture over the top of it is totally against orthopedic principles. And we get away with it constantly, day in and day out. So I know people in this group are worried about mercury causing problems, but if you're an orthopedic surgeon, this would be the big problem they would think about when they think about dentists causing jaw issues. Well, I happened to become friends with a guy from Texas, Bob Jones, and he called me one day in the early 90s and said, I got this Nico disease, and I went to a guy in Colorado and he took care of it, and now I'm madder than hell because I went to so many docs, and he was told, well, this is going to kill you, whatever it is. And this dentist found 3 of these bad areas in his jaw, cleaned them out, and then said, call Dr. Bouquot. He can explain what goes on. So we had a long conversation, and he said, well, I'm an ultrasound engineer. I have a company. Do you think if I developed an ultrasound we could use in the mouth, that would help find these things? And I said, sure. So 5 years later, he gave me another call and said, hey, Doc, I got the machine. I'm bringing it out. and he brought it out, and I had some of these jaws, and we had some dried skulls with holes in them, and it worked very, very well. So I started collecting data from people who were sending me biopsy samples in addition to the ultrasound images. And he wanted to get FDA approval, and I called the FDA and I said, is it okay if I'm doing the research? And they said, yeah, it's fine. So I had to go to the FDA 3 times to explain the disease first, and then to explain what I was doing. And finally, they wanted in writing what was happening. And you see that we found that the study that is published now in a textbook authored by the 2 head device people for the FDA. It's a summary of a symposium that they held. And a book chapter, one of the chapters in that textbook is about this QUS study. I had 339 cases. Somebody up in Canada looked at all the edentulous or implant possible sites and used ultrasound. We did another step. We used low-level light therapy to try to improve the bone density. Quantitative ultrasound only picks up bone that's dry. It only picks up bone that is cavitated, and it only picks up bone that is regular or high bone density. I mean low bone density, sorry, osteoporotic bone. Those are the 3 things that it's FDA approved for. And the FDA actually asked me to write out the formula for what this device would be used for. So I know that because I did a lot of literature review for that. So any positivity is not going to show up on x-rays. You can have perfectly normal looking x-rays. And 25% of all of the edentulous sites that we found using quantitative ultrasound were positive, and the average was on a 4-point scale at 2.4. And I can tell you it's not part of the study, but the light brought about 40% of those down, at least 1, sometimes as much as 3 grade points. And I guess I might as well explain in the picture that's been around the block a few times, but this was a fellow who, believe it or not, I sent to an endodontist, or the endodontist had him call me. Totally edentulous man. He'd had trigeminal neuralgia for 7 years, and he had gone to these endodontists. They found some funny places on the x-ray, and they removed 3 sites, and his trigeminal neuralgia was gone. Well, 7 years later, it starts to come back, and he went into a panic mode. He was manic depressive, and he went into his manic or depressing stage, actually, and he took an overdose. And on the suicide note on the side of his bed, he said, "Please send my head to Dr. Bouquot." So my 15-year-old boy got a call from his wife saying, "How do I get my husband's head to you or to your dad?" So long story short, they were from Indiana, and I had from Indiana University friends, and they said, "Well, if you can just send us a jaws, we'll fix them and send them to you." And eventually I published it in one of our really highly regarded journals, and I could say that 2 of the peer reviewers for that paper, they both said, "Wow, super interesting," and stuff like that. They'd never run into this kind of a process before. Now, of course, it's very common for me. Well, so essentially, I'm saying that by far the most common diseases in the edentulous portions of the mandible, we just haven't studied where the teeth are yet, but at least in the edentulous portions, we've got either dry bone or we've got chronically inflamed bone. And the study that came from, by the way, was not my study. I didn't even know this was going on until a couple of years later I read the paper. But you can see the results here. We have 16% of these are perfectly normal. I mean, they were going to have implants put in. And I don't have any follow-up, unfortunately, but they were perfectly normal looking bone, if there is such a thing as a normal bone on an x-ray. And 16% had chronic osteomyelitis, diagnosed by these 2 oral pathologists. 35% had osteonecrosis. That was their name for it. and non-viable bone was a big part of their picture. So we're dealing with something that the orthopedic surgeons have no concept how to deal with. I mean, infection in their bones is a life-threatening phenomenon. In the jaws, you get an infection at the end of a tooth. If you would put the end of that tooth in the femur, in the mid portion of the shaft of the femur, and just let that pus drip into the middle of the shaft, that pus would go from one end to the other within a few weeks. It would perforate multiple places through the cortex, and it would start causing soft tissue fistulae and redness and edema. In the jaws, what does it do? If it gets out of the bone at all, it goes to the hardest place, the cortex, the closest cortex, and eats its way through and then pops out onto the gingival tissue. Sometimes it'll cause some swelling to the face. Sometimes it will cause a fistula to the face. But that's just not natural. And if you look at the picture I have on top is a periapical granuloma. It's been washed out in the middle because it had pus centrally, and that just doesn't last in our processing. But if you look at the bone on the outside, it's not mature bone, it's new bone. I have 76 cases of the bone around periapical lesions. And it took me 30 years to collect those because we never get bone in those periapical biopsies. But all of them have this immature or newly forming bone. And that means there's something else that's unique. We're the only bones in the body that can allow a localized collection of inflammation, chronic or subacute, and walls it off with continually remodeling new bone. I think some of these abscesses, certainly before a biopsy is done, they've probably been there for months, maybe even years. And I just have never seen mature bone around a periapical infection. So there's something about our jaws that allow that bone to wrap a Band-Aid around that doesn't occur in the long bones. And that something may have to do with the fact that we have, because of the bisphosphonate research that's been done, we know that the alveolar bone in the jaws turns over on an average 6 times faster than regular bones, non-jaw bones. And there are some people who had jaw bones that turned over 20 times faster. And I presume, just an assumption, I have not done any research in this area, but I presume that the reason for that is it's got the ability. I suppose one way you could put it is either Mother Nature or God knew that we were going to have tooth decay and we had to have our teeth in special bones. It's a good explanation, as good an explanation as any, but we do have really, really, really unique bone in the jaws. And we could not do the stuff we do, surgically mostly, if that bone was not good. And we could not have periapical abscesses. We literally could not have periapical abscesses if we didn't have a unique bone that would allow that abscess to wall off. And I have no idea why the abscesses go directly to the closest cortex. That's got to be something really unique, but that's a mystery that I'm probably too old to solve. Well, we have chronic osteomyelitis. We have chronic ischemic bone disease. And they're supposed to be 2 different diseases. But in the jaws, there's a lot of overlap. And I told you initially the first 5 years, I was calling them all chronic osteomyelitis. It was amazing me because we're not supposed to have much osteomyelitis. But once I got onto the ischemic business and went to all these medical pathologists who were hip osteonecrosis experts, they pretty much confirmed that I was dealing with ischemia. But I have a lot of friends in oral path who still prefer the chronic osteomyelitis. Well, I did a follow-up study of these individuals, and 72% of them, on an average of 5 years after their last surgery, were pain-free. And some of these people had been in pain for 20 years. They were called neuralgias by their local physician or neurologist. And yet now they're out of pain because, well, eventually I had about 5 oral surgeons around the Morgantown, West Virginia area who were helping me out with this. Well, if in fact we have all of this that's pain-free, I literally had people tell me that I made up the data. And in today's world, that's not an uncommon thing, especially with the so-called predator journals where they'll just take anything. And a lot of people, mostly in other countries, are making up data or copying somebody else's data and putting their name on it. I didn't really do that, but I was the only one who looked at all these cases. So I sent off samples to friends, and they pretty much agreed with at least the inflammatory changes. But I was so frustrated with people saying I'm the only one who sees this that I called my friends in Indiana University, Susan Zunt and Larry Goldblatt was the dean, and I said, look, these endodontists in Indianapolis, they're sending me a lot of tissue, all of their tissue, not just this Nico stuff. Would you mind if they send it back to you? Because I had felt guilty taking them away from their biopsy service. And then when you get enough, would you write a paper and just kind of confirm or deny what I have been assuming all along? And they just published that paper, I think last year. Larry Goldblatt is the first author. He was the dean of that school for about 12 years. And then when he stepped down, this was his research project. They had over 300 sites of involvement. And he called me and he and I talked for a long time. He said, I don't get the ischemic part, so I'm going to call them all chronic osteomyelitis. Well, he did a follow-up study of about 83 patients, the ones who returned their follow-up letters, and he found an 83% pain-free episode up to 15 years after the surgeries. So I think the fact that going into somebody's jaw when they have pain, if you do identify an area of involvement, is worth doing. That's been confirmed. I don't think we have to question that anymore. Well, if we're going to look at these 22 things that are different about the face, I've got them here, but I'm not planning on going through them, but I did want to at least outline that 4 of them have to do with this thing I'm talking about today. We are by far the most ischemic bones in the body. Both the artery studies as well as that the implant studies have shown that. We're the only bones that are usually inflamed and ischemic. And we're putting implants into all of this kind of bone. Wouldn't it be wonderful if we could do follow-up of cases that are positive with ultrasound, for example, and identify something that is low bone density, and then put an implant in and see if that has the same success rate. But that's for other people to do. We also have more internal voids in the bones, and I think that a lot of those are leftover residual sockets. I've got a paper that I've already presented at a national meeting. It should be sent off to a journal sometime in the next few weeks. It's about, I call them residual sockets. Believe it or not, there's almost nothing written about it in the dental literature, and yet each and every one of you see these probably on a daily basis. You look in the jaw and you see there's an outline of an old socket, or there's a little round radiolucency because there was a little bit of remodeling that happened after the tooth was removed decades ago. And you're like me. You've seen that so many times and it didn't seem to be associated with a problem, so you just assumed that it was okay, just variation of normal, but it's not. It's a pathologic condition. I have over 75 biopsies of those things, and it is probably, by and large, most of them are hollow. Others are filled with dense fibrous scar tissue. Others have chronic osteomyelitis, and there's always something abnormal about it. And I'm not saying you have to do anything different, but at least you should recognize it. It's probably an example. This is somebody who's maybe got an ischemic body, or something is in their mandible. Maybe they've got that artery that's all constricted by now. And the constriction seems to start somewhere in the 40s, or it becomes noticeable by the people doing the studies. And then also, you didn't know this. I didn't know this. I wouldn't know it if I didn't read all the bone literature. But osteoporosis in our jaws is focal. And I think most of them are old residual sockets. It just doesn't heal properly. And the only thing that would make it not heal in that fashion is slow cutting off of the blood flow. So it can't heal properly. Then you end up with osteoporotic bone. So we're literally the only bones in the human body that have focal osteoporotic marrow defect. And that's pretty unique. Who knew? If I didn't do a whole bunch of reading in the orthopedic literature, there's only one long bone example of focal osteoporosis, and that is when you break a leg, if the blood flow doesn't cross that healed barrier, then you will get maybe 1 centimeter or 2 centimeters downstream in the bone, there will be a little area of focal osteoporosis. It's the only form of focal osteoporosis I can find. So that's a pretty unique phenomenon. And it's pretty common. I think you probably see focal osteoporosis maybe once a month at least in your practice. Well, how do we know that it's ischemic? The classic example is the bone cells are dead. There's no difference at all after we process our tissue between living and dead bone. It's just that the cells are gone. And you can screw it up in the lab. Most labs do it that way. We're interested in cancer, so we want to decalcify it with a heavy-duty sulfuric acid or nitric acid so that we can look at it and get a diagnosis out the next day. To process bone for studies of ischemic damage, you have to put it in something that is, well, formic acid is what we use. And just because I have this little boy still inside me, little 6-year-old boy, one day I had a beaker of formic acid and I was reading a book and I just put my finger in the formic acid and waited to see how long it would take before it started to hurt. And it was 23 minutes. And it didn't hurt very much. So these little chunks of bone, it takes 5, 6, 7 days for us to decalcify them properly. And you have to look at it every day. It's a lab nightmare. And I had to go and train my lab techs to process this stuff properly before I could even do these studies. So the fact that the bone is dead really doesn't mean much, I don't think. But if you look at this is a lamina dura, this little tooth up here in the top. But you see all these lines. Bone that is created under ischemic conditions could also happen under malnourished conditions, but it's created under ischemic conditions has a lot of cement lines, prominent and excess cement lines. And that's what orthopedic pathologists have used to say that this bone is created under ischemic conditions. And you also notice there's a little crack here. It's not an artifact, or if it is, and it's artifact because pathology is there. It doesn't hold because these cement lines are weak spots, it opens up. Whether it opens up in real life or it opened up when we cut it, we don't know. But they're called microcracks, and it's a sign. You only see microcracks in bone that's created under ischemic conditions. And it's like looking at those residual sockets. I didn't realize they were there myself. You don't realize they're there yourself, but from now on, you'll see most of them. And you won't worry about it, but at least you'll see them. But this is the same thing. I saw them all the time and didn't think anything of it. I thought it was just a piece of broken bone from the lab. But there's a different look to it. So microcracks are part of the problem, and it's a diagnostic issue. And also, you get very few osteoblasts. It's pretty inactive bone when it's been under low oxygen conditions. So this is what osteonecrosis typically is. But chronic ischemic bone disease is actually a bone marrow problem. You've got congestion. The blood pressure inside the bone might be 4 and 5 times higher than the blood in the soft tissues because the blood has a problem getting out. And when you get really sluggish blood flow, then if you have one of these coagulation tendencies, then you're going to throw clots in that sluggish blood flow area. And if it happens to be your jaw, then you're going to throw a clot, and that's going to be a painful condition for you. and downstream blood may actually dry out the whole mandible. Lack of downstream blood. And this is just an example. We've got the more toward the anterior, but this is what normal bone looks like, and this is in a dried skull, what normal bone looks like. And then here is a mandible with NICO or ischemic osteonecrosis, and you can see the nerve has this glistening stuff around it, and that is called gelatinous marrow. It is something that's seen only in starvation and in this disease, chronic osteonecrosis. And I got curious, and I had one of my ortho residents was doing a thesis using dried mandibles. Got them for $98 each. I didn't ask where they came from. And but he was cutting them lengthwise, as you can see. And I said, well, why don't I take, I was using quantitative ultrasound at that time. I said, let's see if we can find any holes. And then if you cut them open and we find them, that's a little study. And we did that, and about 1/3 of them, of the 28 dried skull mandibles, had these hollow spaces inside. And a hollow space is not an artifact. You don't get in a hollow space because the mandible was not well preserved. So it's a real process, and it's different from a socket where a tooth fell out or something. And somebody once tried to prove that I was wrong and said everybody has these hollow spaces. So he cut up, University of California in Los Angeles, he cut up 20 mandibles, and he looked at them. These are fresh mandibles and cadavers, and he found that 1/3 of them had these hollow spaces, and he thought, well, that proved that I was wrong because that's normal. But he just didn't know enough about bone. And but he and I were in the process of trying to write a common paper about 4 or 5 years ago, but then he died, so don't be a co-author with me. And then I've talked about these residual sockets as well. And here's an outline you can see up in the x-ray. This is decades after the tooth was out, a molar, and you can see residual socket. Another thing that you can look for, but you won't see it if the lights are turned on in your operatory. In orthopedic surgery or radiology, they call it ghost marrow. And that's just a very faint haze, like a ground glass bone, but very, very faint. And ghost marrow is a sign of ischemic osteonecrosis. And histologically, there's some more residual sockets with ghost marrow below it. But histologically, I'm not going to get into any detail, but that upper picture, you see all this pink stuff? That is from that high blood pressure. Serum oozes out of the blood vessels, and fat cells die and coalesce and get together. They're called oil cysts, and they're just floating around in this serous ooze. In Europe, they call it plasmostasis, and I like that name, so that's what I use, but others use serous ooze. And then here's a socket, one of the sockets that shows immature bone formation. It's brand new looking bone, but there are no osteoblasts there. It's no longer being formed. It was able to be made, but never matured. And presumably that's because of the ischemia. And then the hollow bone, of course. This is from a review paper that I wrote. This is one of the hollow bones. It just has a cadaver bones in the study. And I just wanted to show that the x-rays don't tell you anything. You can lose, 50 to 80% of the cancellous bone, and it won't show up on an x-ray. That's been about every 10 years somebody does that study and publish it. And the best one was done back in the early 60s, published in the ADA journal. They literally took dried skulls and went in and just curated out the whole inside and glued it together, took another x-ray, looked the same as the first x-ray. And that's because radiographs only make a difference if you take, if you smooth off the cortical wall, then you can see things very, very well. So radiographs haven't been the best tools, and in dentistry, that's a tool that is almost glorified. We use it so much. Just some more examples from this paper that I'm about to send off. Anybody who wants to look at it, you're welcome to. Some of the hollow spaces, bone marrow often is just mushy. You could literally take your finger in and scoop it out, and yet microscopically it doesn't look very unhealthy. It just is ischemic. And here's some more cases. That top case, the x-rays go with the clinical picture or the gross picture, and the one on the bottom or on top shows that everything under the inferior alveolar nerve is just mush, literally mush, and it has destroyed the wall of the inferior alveolar nerve. So we've got this, all the cytokines that go along with inflammation are seen in ischemic bone disease, and we have a Hans Lechner over in Germany has been looking specifically in these SNECO types of lesions for cytokines, and he's found they're in very high numbers in virtually everyone he looks at. And of course, the assumption is if they're in that lesion, just like a periapical abscess, what is spilling into the system? What is going into the rest of your body on a daily or hourly or minute basis? And he is also, he's developing another quantitative ultrasound for dentistry. There's one developing in Germany and one in England. And of course, from my reading in the orthopedic literature, they said to find osteonecrosis in the hip, you really have to do bone scans, scintigraphy. So I did bone scans. These endodontists actually were across the road from a hospital. So they sent hundreds of their NECO-type patients across for a bone scan. And I spent many weekends in Indianapolis trying to abstract all of their data. And we finally published it, and we found that if there's a hot spot in the area of pain, then 97% of the time there's going to be either chronic osteomyelitis or ischemic bone disease. And that's looking at it microscopically. I have another paper that's only partially worked up, although I presented it at a national meeting, and that is with diagnostic anesthesia. I gave up on the bone scans because diagnostic anesthesia was also 97%. If you put a little dab of anesthesia right where the pain is and the pain goes away, and then the pain comes back and you try it again the next week and the same thing happens, then biopsy that site, and 97% of the time you will find ischemic bone disease or chronic osteomyelitis. So we just haven't been using the right tests, I guess. And we're thinking about teeth. We do think now with all the implants and bisphosphonate stuff, we're thinking about bone a lot more than we used to. But this is a disease, maybe you can't see it on your screen, but there's pink in where all the fatty marrow should be. And that's because collagen is the one that can live, the tissue that can live without any oxygen or nutrients. And so that replaces the fat cells. But it's a disease between the teeth, disease beneath the cortex. And our usual ways of thinking, finding periapical granulomas and tumors and cysts using radiographs, this is a marrow disease. You can have a mandible completely full of lymphoma or leukemia, and it would look perfectly normal on an x-ray. So we've just been fooling ourselves into thinking the radiograph could tell if something was normal or abnormal, and I'm here to say there's no such thing as a normal bone on a radiograph. You can say you don't see no obvious pathology. That's the way to say it. Don't get me wrong. I say, oh, that's a normal. That's normal. That's fine. But you should at least know in your head that there is no such thing. You cannot look at an x-ray and say this bone is normal. And this is one of the diseases that proves that. And I think I'm out of time, or do I have 2 minutes? All right. Then this is another interesting phenomenon that I found. I told you there's this kind of immature bone wrapped around a periapical granuloma. Well, this is a case that's in a really big chunk, including the root tip. It just happened to all come out together. And I have noticed that, and it's another little research project I've been trying to put together for several decades. If you look at the periapical granuloma, there are areas of pus, necrosis, chronic and acute inflammatory cells. And then you go a little further out, and it's more fibrosis and just chronic inflammatory cells. And then you hit the bone. Well, bone is pretty porous. You would think that the cytokines or the bacteria, bacterial products would be just pouring through, and you would get an osteomyelitis outside. outside of this wall of tissue around the granuloma. I almost never see that. I think I've had 2 cases where the inflammation was actually outside in the bone marrow, and a couple more maybe that were ischemic outside the bone marrow. No, more than that, maybe a dozen or so were ischemic. So it's, number one, it shows how effective that little process is of walling off the tissue, the inflammation. But it also, I mean, what a mystery. What is there in that bone that keeps even the holes from allowing bacteria to get through? You know, I'm not a young guy. I'll be 76 in another month or so. And I'm not sure I've got any more left in me. So some of you are going to have to take over and answer some of those questions. And I think I'm out of time.